So mitral regurgitation is a very common disease, particularly as all of our population gets older too. To put it into perspective, where of late there has been an explosion in the growth of transcatheter aortic valve disease, when we look at all of mitral valve disease, it actually is a higher degree in prevalence. Now, of mitral regurgitation, there's two types. There's primary or degenerative mitral regurgitation, where it's a disease of the mitral valve. And there is secondary or functional mitral regurgitation, where it is a disease of the ventricle, and secondarily, the mitral valve is affected. Now, what we're talking about for this is primary mitral valve disease, which we have studied and have provided therapies for a number of years for. The transcatheter therapies for primary mitral valve disease was approved by many regulatory agencies between 2011 and 2013. But since then, there has been no additional studies after the original Everest 2 trials looking at the results of transcatheter therapy, such as the MitraClip, in a core lab adjudicated fashion in terms of outcomes for how well we're doing with it. And that leads us to the purpose of this present study, the EXPAND study, which is looking at the core lab adjudicated clinical events committee adjudicated results of the current generation of transcatheter mitral valve repair with the MitraClip NTR and XTR systems. So the primary objective of the EXPAND study is to report out the real-world Echo Core Lab and Clinical Events Committee adjudicated results in treating patients with significant primary mitral regurgitation with the next generation MitraClip, the NTR and XTR systems. And this data comes out of the more than 1,000 patient global EXPAND study. We also had secondary objectives to evaluate mitral regurgitation reduction outcomes as a function of the underlying mitral valve anatomic complexity, as well as to confirm the safety, including single leaflet device attachments and leaflet injuries as it relates to the NTR and XTR systems. So overall, that EXPAND study design had an initial intended study sample size of over 1,000 consecutive patients. Those patients were enrolled from more than 60 sites, and we had follow-up out to a year, although we're reporting out right now the initial follow-up period of up to 30 days, and with multiple outcome measures. And again, the data was adjudicated by a clinical events committee, by an echocardiographic core lab, as well as an independent physician committee that is utilized to evaluate leaflet injury events in SLDA. As far as the key outcomes goes, particularly in terms of procedural outcomes, what we found with the EXPAND primary mitral regurgitation study, we had a very high rate of not only implant rate, but acute procedural success rate at 94.5%, as well as relatively short fluoroscopy times, procedure times, and hospital length of stay for the index procedure. This was particularly impressive when we compare this to the previous clinical trials on this in prohibitive risk primary MR from the Realism and Everest trials, as well as from the more recent TBT registry. We also found that in this study, we found that the XTR variant of the MitraClip with the longer clip arms was used more frequently to treat primary mitral regurgitation than the NTR variant. However, the baseline degree of MR severity was statistically different across all three device groups, with more XTR usage in subjects with greater degrees of baseline mitral regurgitation. We found, though, that the pre-procedure inflow gradient, or how narrow the valve was not different across the clip type groups. And we found that the MitraClip NTR variant with its longer clip arms was not associated with an increased mitral valve gradient post-procedure compared to the NTR clip. In terms of 30-day major adverse events, we found that the all-cause mortality was low at 2.4%, stroke 1.2%, and just under 1% of cases had the complication of non-elective cardiac surgery for device-related complications. We also looked at device-related leaflet adverse events. And again, for this, we had an independent multidisciplinary physician committee headed up by the Echo Core Lab, which looked and adjudicated all such injury events and found that there was 8 instances, or just under 2%, of single leaflet device attachment and 1 case of leaflet injury. The Echo Core Lab looked at mitral regurgitation severity, and at a baseline, 2/3 of the subjects had 3 and 4 plus mitral regurgitation as adjudicated by the Core Lab, with 1/3 having lesser degrees. Although of note, how the EXPAND study was set up initially is that the sites had responsibility for adjudicating on study entry that all the subjects had 3 and 4 plus MR. So I think having 1/3 of the subjects having lesser grades of MR as adjudicated by the Echo Core Lab confounds some of these results. So what we did, even though these results were excellent, we then separated out by baseline degree of mitral regurgitation how much MR the patient had at baseline, at discharge, and at 30 days. So on the right side of this slide shows just those subjects that the Core Lab adjudicated that their baseline mitral regurgitation severity was 3 or 4 plus, which was evenly split between that. But at discharge and again at 30 days, we had fairly impressive outcomes, such that 21% of patients had no residual MR, 83% had 1 plus or less, and 96% had 2 plus or less. When we compare this to the results from the earlier Everest and Realism trials, we found a significant difference with MR reduction to 1 plus or less at 30 days numerically greater in the EXPAND study compared to these previous trials. In the EXPAND study, we had an Echo Core Lab evaluation of anatomic complexity of the mitral valve disease and found that just under 1/3 of patients were adjudicated as having complex anatomies. The majority of these were the presence of extremely wide mitral regurgitant jet, calcification in the landing zone, or the presence of severely degenerated leaflets. And in these subjects with adjudicated complex mitral valves, we found that they had greater degrees of mitral regurgitation at baseline compared to subjects with non-complex anatomies. However, the degree of reduction of MR in complex versus non-complex anatomies was equivalent. Yes, we did find that there were differences in the use of the type of clip as it relates to the anatomic complexities. We found that the XTR clip with its longer clip arms was more often used in subjects with larger prolapse in flail gaps. And in terms of the outcomes, how well it reduced the MR, we also found that greater MR reduction was achieved using the XTR clip in complex anatomies. I think one of the takeaways from this is these next generation clips, the NTR and XTR, are safe and are efficacious, similar to what we've seen before, but with improved efficacy in terms of the procedure times are decreasing. Now, part of this is probably related to operator experience, the improvement in imaging, but also part of this is probably related to the improvements in design as we're seeing with these next generation clips that's allowing the operators in a real world practice to get better and better results. EXPAND has not yet specifically looked at the results of correlating between outcomes and experience of the different sites involved. From an anecdotal standpoint, we certainly have found that the MitraClip XTR with its longer clip arms does make it easier for operators with lesser degrees of experience to get better results. However, we'll have to specifically drill down to answer that question in future iterations of the study. The first thing that we're continuing to do is to follow these patients out for greater periods of time. So we have up to 1 year's worth of follow-up data. That is actually going now, and we hope to present that shortly. The second thing is the MitraClip is continuing to be in evolution. The NTR and XTR variants are just the current iteration, and soon to come is the next generation, the G4 variants, which will need to be studied as well, as it introduces increased capabilities along with increased complexity to the armamentarium physicians have to treat primary mitral regurgitation.